Hi. All of us as parents have this great worry about what's happening with our sons and daughters because we can't necessarily be close to them. There are many questions and anxieties that parents have. So, in a conversation with one parent, Jill, whose daughter is in one of our homes and who actually coincidentally was at college with my own daughter many years ago, Jill is a nurse, as she explains, and we said, look, Jill, why don't you make a whole load of questions and ask Hazel, who's our learning disability nurse, those questions. And if you don't mind, we'll record them because then it's a way for other families, parents, and carers to actually, to see what these issues are and just to sort of feel the emotion and so on, because obviously there are emotions there. And as much as we can do to reassure you that we are doing everything, we're very, very happy to be given the 10th degree by another parent. So over to Jill and her questions.
Hello, I am Jill McNeely, one of the parents of an individual at Home from Home. My past history is a medical past history, so I am an actual a registered general nurse and a state certified midwife. So I've been asked to sort of represent the parents' questions, so I have put quite a few questions to Home from Home regarding the risk aspect of the plans that they may have in place if something tragically goes wrong with the coronavirus situation.
Thank you very much. And I'm Hazel Ashmore. I'm a Senior Microclinical Manager for Home from Home Care, and I'm going to endeavour to answer some of those questions for you, Jill.
The first question, I'm sure is on every parent's mind, is what plans do you have, Home from Home have, in place if an individual shows signs of the CV virus, i.e. a sore throat, temperature, etc.?
Okay. Well, our system, our own standard platform, allows us to record lots of information, activities, etc. And one of those things is observation records. So observation records can be things such as breathing or temperature, as you've mentioned, but they can also be for like skin or body. So if somebody notices a bruise, for example, or something like that, there's observation themes, if you like. So there's probably about 10, 11, 12 of those themes. And what we can do within the system is we can log certain aspects of those to alert to us immediately. So, for example, ordinarily, if somebody were to vomit, whilst that's not something nice to happen, it's not something that is a clinical emergency. However, if they were to vomit with, say, what looked like blood in it, like what we call coffee grounds vomit, then I would want to know about that straight away. So what we've got set up in the system is that I can say, right, if somebody says this has happened, I would get an immediate alert that that has happened for one of the individuals we support, me and my team would. So having that as a basis has given us a really good platform to be able to look for those symptoms of coronavirus. So for example, ordinarily, a cough wouldn't be something that would create an immediate alert. But for the time being, we have set it to be an immediate alert. So as soon as a staff member says this individual has coughed, the health and wellbeing team and the locality team are aware of that, and the same for temperature, and we're able to set the range for that as well. So we've set the system, we've told the system what is a normal body temperature up to 37.8, and again, anything that goes above that, we will get an immediate alert. And what we've done in terms of plans is that we would then implement an isolation protocol. So what that would mean for each individual might differ slightly, but basically we would restrict that individual to their own apartment or room or whatever it might be for that 7-day period.
But as far as the temperature and sore throat, you're using your platform,
yes,
obviously, for this. And then you make your decision, obviously, whether it's going to be going to the next step. Yes. Now, my second question was that the government guidelines, as you rightly say, is isolate for 7 days.
Yeah.
Can you provide this facility, or would your plan just be to watch and wait?
Okay, so yes, in short, the short answer is yes, we can provide that facility, whereas it wouldn't be classified as a proper isolation facility as it would be in a hospital environment. But what we've done is, for each individual that we've had to isolate so far, which has been 4 or 5, we restrict them to their apartments. Now, if that is an apartment that is already separate from the main communal areas, i.e. it's an individual who perhaps needs support to be able to mix with others and perhaps doesn't do that routinely, then it's easier than in an environment where there is more readily access to communal areas. What we've done in those areas is we've tried to say, okay, well, we've got 2 living areas here. Let's restrict this living area for these people that are in isolation, and they can at least go to that area as well. So they're not completely restricted to just a bedroom and maybe an ensuite area if that's all that they have. And what happens is that if they are using that communal area, either if it's possible, it will be restricted for their use only. But if it isn't possible to be restricted for their use only, we clean and sanitize before they go in and after they come out on every occasion.
Okay. So basically, you've answered the question in terms of you do have plans in place.
Yes.
To isolate.
Yes.
Right. Now, as the individuals are not able to be alone in isolation, that does have to include the existing staff.
Absolutely.
Now, my next question is, would you be able to staff this in-house?
Yes, and we have done. So as I said, we've had 4 or 5 individuals already that have gone through that 7-day or in one case extended to 14 days isolation. And we've also got 2 individuals that are being isolated for the full 12 weeks because they've had that NHS letter. So what we're doing is minimising the staff that work with those particular individuals. So we would have a separate rota for that individual, and only a minimal number of staff would work on that. And we've also minimised the rotation of staff across different settings as well. And there is a protocol for staff going in and staff coming out.
Right, that was obviously going on to my next question. I mean, at this stage, alternatively, I've put, would you be calling 111 the expectation of admitting the individual to hospital, even though the symptoms were mild, in which case hospitalisation might not be appropriate? So we've now got them isolated.
Yeah.
This is not a question that I've put in, but presumably, are the parents informed when someone goes into isolation?
Yes, yeah, we've been keeping them informed, because as much as possible that is still a restriction on that person, and whilst it's government sanctioned and therefore is in their best interest, we still need to make sure that everyone that should be involved in that decision making process is. And quite often family have different ideas of how that might work better for the particular individual, especially if they're going to struggle to understand why all of a sudden they're restricted to where they can go.
Yes, well, that's very good, because obviously we're quite fortunate at the moment, because I haven't been informed that an individual in Pippa's house has been isolated. So
No.
Obviously I didn't know that. Right, going on from there is what you were just talking about there, the constant movement of staff. Now, this is obviously a problem on a daily basis. It creates a severe risk to bringing in the virus, because it actually does not comply with government guidelines. But there's not a lot you can do about that, in terms of no movement whatsoever, which is what we are in now. So I understand the difficulty, but as you answered before I could ask, would it therefore be possible to limit the movement by amending rotas and perhaps include 2-day shifts with sleepovers? Now, I have to ask you to answer that again, because this is going to go out to the parents.
Yeah, absolutely. So as we've said, we would minimise staff on that rota. So where possible, we would have just a few members of staff working that rota. And we've also put into place a volunteer standby rota. So, for example, how our system normally works, the resource team across all 11 homes works centrally. And for example, if somebody called in sick, even without coronavirus, on another site, and we had overcapacity in site B, for example, ordinarily that member of staff would be moved from site B to site A to cover that shortfall. We're trying to minimise that as much as possible by having, and one of the ways we're doing that is having a standby rota. So in location A, there will be people volunteering to say, I'm not on shift next Tuesday afternoon, but I will be on the standby for that late shift if somebody has to isolate on that day and they can't come in. So we've already got another kind of level of approach before we have to resort to go into another location to make sure we've got enough staff.
Do you have facilities for sleep-in staff?
We do in some locations, yes. Yeah. So we do have sleep-ins on some occasions.
Okay, so this actually, even if you've got extra staff to cover the shifts, you've still got the problem that you've got 1 in, 1 out, 2 in, 2 out, and this is a constant movement.
Yeah.
Would it not be possible to do sleep-in shifts like on a 2-day basis where they have a sleepover to minimise the same staff that comes in on a Wednesday and on a Thursday, doesn't go home, but stays there for those 2 days and 1 night, which in itself would minimise the amount of staff amount of time that person is entering and leaving the building.
Yeah.
Now, I do feel this is a bit of a weak link, really, because it's almost like us here locking down and then inviting someone into the house for 12 hours a day from outside. So I wonder if it could be minimised in that way, because it's got to be, you've got 2-3 staff going in, 2-3 staff going out, etc., etc. Perhaps if they were on a 2-day rota with a sleepover, it might just limit that a little bit.
Okay, so that will happen on occasion, but it's not something that we do routinely. The other important factor that we need to, so going back, you said about the government guidelines. So the government guidelines for care home provision is different because obviously, as you've rightly said, it's a different scenario. We do need to have people going in and out. There's no avoiding that. So we are adhering to the guidance in that respect that has been provided for care homes, and that is available on the gov.uk site if you wanted to have a look, or I could give you the link afterwards if you like. But the staff, we've also got a report for the number of hours that staff are doing, because obviously we are picking up extra shifts. They're very committed, but we've got to make sure that we keep track of their well-being as well. And make sure that they're rested, because at the moment I think this is the lull, particularly in Lincolnshire, is maybe the lull before the storm, in the sense that the peak is coming. The peak has happened in London, but I think we're kind of 2 or 3 weeks maybe behind in the Midlands and Lincolnshire. So we're very aware that we don't want to burn our staff out, and we need to make sure that their well-being and their mental health as well is kept as high as possible, so that we can encounter that when we come to it.
So going back to this bone of contention that I have about this movement, well, it really is quite a difficult one, because you say then that the government guidelines quite specifically say that the care staff can come and go as and when. Now, surely there must be, do you not think that in that scenario there is an opportunity, shall we say, for home from home to perhaps just try and limit the amount of comings and goings that's happening?
I think we have done that quite successfully by minimising the staff rotas, so people aren't travelling between locations. They are coming in for that shift. They're working sometimes 8 or 14-hour shifts. So we have minimised that. Over on top of that as well, there are protocols for staff when they arrive at work and when they leave work at the end of the shift, and for when they arrive home to protect their own households as well. So I'm quite confident that we've got that quite well covered.
Now, are you yet on a par with the NHS frontline workers regarding testing?
So there's 2 drive-through tests started in Lincolnshire this week, and they are invitation only. So at the moment, the testing is just for hospital staff. I believe that the next lot of testing after hospital staff would be for social staff working within hospital settings, and then it might be rolled out to social care staff. I think the media coverage is starting to appreciate that it's not just NHS that are frontline workers, that social care staff are very much frontline workers. But in terms of testing, that's the latest information I've got at the moment.
Okay, well, I hope they bring that in soon, because I think that's vital. My next question, and forgive me for this, was, do staff have access to an in-house nurse that they can call on for advice? But I see that they do, and you're very well equipped to answer those questions.
Yeah, so my background is a learning disability nurse, so I've been qualified for about 25, 26 years now, and I lead a health and wellbeing team as one of the intersourcers. So it's not just myself, the rest of my team are looking at the data and information on a daily basis, and we would be doing that ordinarily regardless of coronavirus. So for example, we would look at screening tools, where are risks for health, what the control measures for those risks might be. So is somebody at risk of nutrition? We would be helping staff with support with appointments by providing data, for example, on epilepsy and seizures and those sorts of things. So it's myself and the whole team really that are available, but in the event that we were concerned about someone, we'd still be utilising the generic services of 111 GP, normal clinicians basically.
If there was a problem, they could call you?
They could, yes, yeah. Yeah, and I have done over the past few days, just even for reassurance and, you know, particular things. The brilliant bit about our system, and for example, if someone's in hospital, is the staff supporting at the hospital can write into the system what's happening, and I can see it straight away. So I can go back to them and communicate via our system, even when staff are in hospital supporting an individual, and say, have you asked the nurses this, or can you get this blood test result, or whatever. So we're advocating for them, even though we're not physically present.
Okay, so that's really the best that you can do. I mean, it's just the fact that when, you know, with the care staff, I always feel they need somebody to turn to when, and they can't phone 111 all the time, because they probably wouldn't get a response anyway. No. It was just, I was concerned that there was somebody immediate that they could pick up the phone and say, this individual is etc., etc. What can I do about it? It was really to help them, because the staff do have a cut-off point when it comes to the medical side of this.
Sure, yeah, and they always have a locality person and a safeguarding person on call. So whoever's on call at that particular time, they'll always have somebody at the end of the phone if they had a query. And if it was particularly health related, then they normally pass that over to me for advice.
Okay. Okay, well look, I think I've covered most things except for the last question, which is really just a feel-good factor booster question. We're all mothers, obviously. If the situation continues for some time, which it could quite well do, will you be seeking relaxing the visiting rules, albeit 2 meters apart, to preserve the mental health of our sons and daughters, and of course ourselves. This could go on for months.
Yeah.
And for instance, my daughter, her mental health is absolutely paramount to her well-being. And she doesn't quite understand, and I don't want to talk this on a personal level, but it really is very difficult for us that cannot communicate by either having them home or by going to see them or by and you, I know you know this, but it's really a question of saying, have you got any plans for us coming out of this?
Well, I think our plans, I think this question is being asked, that specific question, what are the plans for coming out of it, are asked on the daily briefings to the people representing the government every tea time, aren't they? And basically, unfortunately, I'm going to give exactly the same answer. That is, we will go with the government guidelines. You know, we can only do what Public Health England and the government advise us to do. And if that's to continue with, you know, the no visiting policy, then that's what we'll have to continue with, which is why we're doing everything we can to do the YouTube channel, to do communication through other means direct with the individuals, so through Skype or Zoom or WhatsApp or whatever it might be, and using that as a means of communication with the parents and families. I mean, Paul and Anna, I don't know whether you've seen the video of Anne talking about that very situation, because they're exactly in that situation with their own daughter, and finding it difficult to not be able to be physically present with her.
It is a difficult one because some understand and some don't. And for one that's used to coming home or from, you know, communicating on a regular basis, etc., and knowing that they're going to come home or they've got a holiday coming up, it's very, very difficult to try and explain to them that no, they cannot come home, and that will be fine. That will be fine to a certain extent. But I just hope that you know, as soon as is possible, obviously we can perhaps find a way that we can see them on a 2 meter apart basis. But that may not be. That may not be as helpful as it sounds, because we can't touch them, we can't bring them home, we can't. So that may not be the answer. But I was just trying to look for a little chink for the parents of, you know, for the future. But you know, thank you for this. We know that you're all doing everything you can, as I've reiterated to Paul and Anne, through adversity and through these terrible times. It was just that perhaps parents see things in a different way, having these individuals as in our lives. We see things differently because there is an emotional aspect to it. So so we all want these questions answered. You know, what's going to happen if our children get sick? I call them children, I know they're not. So you know, that has certainly helped, Hazel, because I feel that you're on top of it as much as you possibly can be. But what I didn't ask you, was one question. When I suggested that the staff had their temperature taken before they enter the house.
Yes, so as we mentioned before, we've got a protocol for when staff arrive at the home. So obviously new clothing, washing their hands and such like, and the same in reverse. And we've also got protocol for them for when they get home, about taking their clothing off, putting it straight in the washing machine, etc. And we've sent that round to all staff. With regards to taking temperature, I'm not sure that it would gain us anything, in the sense that if we did that at the beginning of the shift, they can still become infected or become symptomatic, more to the point, at any point in the shift. So really, to be effective, you would be having to take their temperature throughout the shift. And then who takes that temperature? And to take the temperature, you've got to be within the 2 meter radius, and also the current data is showing that 5 to 7 days after becoming infected is before you become symptomatic. So in terms of a risk assessment and what it gains us, I'm not sure that it gives us anything over and above what we've already got in place. So I'm not sure that that would be something that we would look at.
Okay, well, I think, we haven't got much at the moment. We haven't got any test kits, and I think it probably is it's the nearest thing we've got to knowing if something is wrong. And as far as 2 meter, rule is concerned, I mean, we have to remember that there isn't a 2 meter in the house.
No, from other staff members. I meant,
yes,
sorry.
Yes, but that doesn't answer the question. That if you took the temperatures before they actually went into the house, I see that there is a 5-day run up and what have you. But if just per chance one of them where the temperature was, I wouldn't say 37.8, because I think by the time it gets to 37.8, that's pretty high. To a degree, it sort of shows there's certainly something wrong at that stage. But if that happened, you would turn that person round and they would go home. They wouldn't even enter the house. Now, that's all we've got. That's all we've got.
The staff are being very good at doing that for themselves, at self-monitoring that, because they're very acutely aware. And we've had lots of staff that have rung up, and quite rightly, either somebody in their household has displayed symptoms, or even if they haven't themselves, they've been very good at adhering to the 7, or even if it's someone in their household, the 14 days. We've had, I think, maybe 1 or 2 instances where somebody has turned up for work and they have been displaying symptoms and we've sent them home again. So we would be looking for those symptoms, but not actually taking the temperature of staff when they arrive on duty.
Is that after they've entered the house?
Yes, yeah. If somebody arrives on shift and we think that they are symptomatic, then we would send them home, or if they've been in contact with somebody who's symptomatic.
Yes, yes. Okay.
They are, on the large part, staff are doing that for themselves. They're quite aware of, the risk that they pose to the individuals we're supporting, and I think most staff wouldn't put any of the individuals in that position in the first place.
No, I'm sure that's the case. It's just the fact that it is the only thing that we have that would show us that there was a problem, and it is a guideline as to why they shouldn't even go in the house.
Yeah.
And if they're taking their own temperatures before a shift, they really can't do much better. But I do think it is important that they they don't become complacent because they feel okay, but in actual fact that's not the issue, that they feel okay. The body can soon tell you if there is something wrong, and I'm sure the staff are very, very good, but they really ought to get used to taking their own temperature before they actually go in, because it's a time bomb, Hazel, waiting to go off, because there's so much movement that you can't seem to get down, really. It's one of those things, but this, of course, in and out, in and out, and in and out. It isn't a perfect world. We know that. And we know that sometimes it possibly will not be possible to stop all this coming and going. But if it was able to be limited and the staff were taking the temperature, I think the parents probably would feel that everything that is done is being done. It's as simple as that. Because I do feel that it is coming towards you. This is very worrying for all of us. And if it only takes one, as we both know, and I just think now that the time has come, if you feel that you can take extra measures, in any way you can, by reducing the shifts or whatever, or taking temperatures, I think now is the time to do it.
Yeah. We've already had that in place for a number of weeks now, reducing the number of staff going into certain homes and such like. So
would they not be allowed to sleep in and and instead of going, would that not be a fairly...
As I say, they have done that on occasion, but we've got to balance home and family life as well. A lot of people have got young children, and they want to get home, and it's mental health and well-being as well for the staff. And having been somebody who's done those 25-hour shifts where you do a later sleeping and an early, you don't sleep properly when you're sleeping at work. You just don't, because you're listening out for everything that might be happening. Does somebody need your help? You might get woke. Our sleep-ins are designed for, if we need an extra member of staff, that person is there to be woken up to be that extra member of staff. So to do that for a sustained period is just not good for the staff, and we need the staff to be healthy and well to provide the support to the individuals.
I only mention it because I do know that other establishments have taken this on, and it works, because it's like distancing. It's so important, and so is movement.
Yeah.
And you're in an unfortunate position where you have got perhaps too much movement. And I just wondered if it could be limited in any way. But I will leave that little problem in your court.
Thank you so much.
But you see where I'm coming from, Hazel.
Yeah, absolutely. Yeah. But I am confident that we've minimised it as much as possible. We're having daily meetings, as you no doubt seen from the YouTube channel. And we're looking at everything from every angle all the time. So it's not to say that we won't come up with something else.
Okay, well, I hope it's been helpful to you as it's been
definitely,
to me.
yeah.
And it's one of these situations where we're all in, we've all got to pull together and bring our strengths together. And if we can glean anything that will bring this to a shorter time frame, then that will be good. And I think this way of talking, as you do as Home from Home, is a great way of highlighting problems. And I know Paul and Anne very well. If there's a problem, they will tackle it.
Absolutely.
And I know they will overcome, because that's the way it is.
Well, that was quite a lot to take in. Thank you very much, Jill, for raising all of those questions, and Hazel for answering them. I think there are just two points I'd like to come back on. One is this issue about staff sleeping over. I'm afraid it's a completely impractical suggestion at the end of the day. We'll have 14 staff on site. We have one sleepover room, and so it's just not set up for staff to be able to sleep over. Number one. Number two, this would have a massively detrimental effect on their own families. We've always got to remember that this is a partnership between us and staff and their families. And in our sort of COVID contingency plan, business continuity plan, the first layer is always about the individuals we support, that obviously is primary. But then everything thereafter is actually effectively around the staff, because it's about making this possible for staff. So we recognise staff have their own lives, they have their own worries and concerns and everything. I can actually say also that we have had a number of staff who have challenged us about sort of people coming into the homes, and we've really listened to that very carefully, and we've taken those things into account. So we are very careful. We are minimising as much as we can that movement of staff into homes. There may come a time, a situation, we hope we won't arrive at that, where we are down to a minimum level of staff. And then I think at that stage, staff will be creative. We have fantastic staff. And they go over and above and beyond on everything. So that's that issue. The issue about taking temperatures, yes, perhaps we ought to look at that a little bit more. I have to be honest, I'm pretty fundamentally against it in the context that everything we do is to try and have a partnership with staff, and everything is around awareness of staff, and particularly awareness, their own self-awareness in respect to the individuals we support. And I think that, we don't want to almost be sort of looking down on staff and saying we're double checking you. Staff are incredibly responsible. The vast majority of staff have a massive sense of self-awareness. Otherwise, they wouldn't be good support workers. And I think it's really important that we encourage them. I think that, if there was an obvious advantage where those are pretty much a guarantee, if you picked up on a temperature or whatever. I mean, we've had, I think it's 53, 54, no, sorry, the highest level is 55 staff who have self-isolated at any one time. They are highly responsible about what they do. And I think in one instance where we have had a member of staff who we actually believe went on to develop coronavirus, we think, we can't be sure. They had no temperature or anything at the beginning of the shift, and actually they started to develop their symptoms in the middle of the shift, and at that stage they left. So I think it's better dealt with, if I'm honest, around this thing of making self-responsibility. At the end of the day, there is only so much that one can actually do, and the thing that you perhaps don't do is you start to create a false sense of security by saying we're going to take your temperature. And then somebody says, well, I'll turn up, and if I've got a temperature, well, then I won't be able to go in. No, that doesn't. So I would, we'll leave that one open. We will look at sort of sourcing some temperature thermometer type things, which could be more practically used. But I don't think we're in a hurry to do that. I do just want to reassure everybody. My own daughter is in one of our homes. I do have the benefit of knowing everything that's going on, which is why we do share all of these films with everybody. And it is an opportunity for you all to know, and we're completely open to any suggestions. And again, I'm really very grateful to Jill for sort of laying out her concerns and sharing them with us. Thank you very much.